Sumantya.
Okay, thank you. Good evening, everyone. Welcome from Indonesia. So, thank you, Dr. Malcolm, for organizing this 2 days webinar focusing on endoscopy. A very nice work, Dr. Malcolm. Thank you. And thank you for having us here. And let me introduce myself. My name is Harman from Indonesia. And I am a huge fan of endoscopic spine surgery and have been performing endoscopic spine surgery since 5 years ago. So let me start my presentation. So if we see this 2 days webinar topics, so it's about 40 speakers. They are covering all different kind of topics, including decompression of cervical spine, thoracic and lumbar, transforaminal, interlaminar, biportal, uniportal. But if you see, among 40 topics, only 7 speakers that are discussing about fusion techniques. So this conclude that we are all comfort in performing our decompression techniques, but fusion technique in endoscopic is still a future, and we are still perfecting our techniques. So among seven topics that are covered in fusion, one speaks about minimal invasive surgery. Three speakers speaks about transforaminal access fusion. 2 speakers speaks about biportal technique, and 1 speaker talk about cervical spine fusion. And this came up an idea for me that I want to share you a technique that I did a month ago. That is fusion interbody lumbar fusion using interlaminar approach. Like Dr. Michael Suber just said, new technique doesn't mean better outcome, but it can give us an idea for our perfection of our technique. So comments and advice are highly accepted in my technique. So this is the case of female 30 years old, spondylolisthesis L5S1. If you see here, it is a dome-shaped S1 sacrum. So it is most likely this listhesis will evolve by time. So the patient complained about lower back pain and right leg pain, failed conservative treatment. So the option is fusion. But so if the patient came to me back on 2013 when I first did surgery, of course I did it in open surgery, conventional way. If the patient came to me last year, I will do it in biportal endoscopic fusion. But this patient came to me last month, and I wonder whether I could do a fusion using uniportal interlaminar access. So the consideration of performing interlaminar interbody fusion is first, the decompression is similar to interlaminar approach, but it is most likely to have more bony work because we have to take out the partial defacet joint in order to place the cage. So another thing of consideration is the endplate preparation. We can do the endplate preparation on direct view using endoscope, or we can do under guidance of the fluoroscope. I will share to you later on. And the most important thing of the technique is the cage insertion. In order to be able to insert the cage using interlaminar approach, you have to have a small enough cage to fit within the working channel, but it have to be big enough to insert. So the answer is you have to use an expandable cage, and the screw placement is conventional minimal invasive ways. So about the cage option, Dr. Christoph yesterday already mentioned that there is a 3D expandable cage that is very suitable, in my opinion, if you want to use fusion endoscopically, but unfortunately it's not available in our country. So the only expandable cage that is available in our country is a 2D expandable cage. So it is only a 3 degree of lordosis. So as you can see, in order to put, we have to know the diagonal of the cage. So I measured it 13 millimeter. So we create specialized big working channel to available insertion of the cage. So the inner diameter of the working channel is 13 millimeter. So this is the technique. So using an interlaminar approach, this is right side symptoms. So the 3 o'clock is the cranial side. So you can see first we work on the interlaminar space, and then we develop within the lateral aspect of the spine of the facet, a medial aspect of the facet. So we chop the facet joint, the IAP and also the SAP. You can use a cutting burr to enhance the faster cutting of the bone. So after you cut the proper bone, you can see the ligamentum flavum. And after you remove the ligamentum flavum, you can see the traversing nerve root of S1, and you can retract it by a dissector and insert the working channel and rotate it. You can use clockwise or counterclockwise rotation to see clearly the disc. So after you fully protect the traversing nerve root like this, then the Endplate preparation process started. So after you punch the annulus, you can enhance the annulus with the Harrison forceps, or you can prepare the Endplate using a burr like this one. So this one you can use a burr. So after that, this is a Endplate preparation under visualized endoscopic view. So after that, we insert the specialized working channel 13 mm, like a simple maneuver rotation to protect the nerve roots. So after this part, everything is guided under fluoroscopic view. See, the important thing that is you must duck inside the posterior border of the corpus. So you are sure you are partially inside the disc. So everything it can be done under preparation of the fluoroscopic view. Like you can use a curette, you can use a drill. Notice here that you can angle the drill because you have a large working channel. So you can catch the inferior end plate, you can catch the superior end plate of S1 as easy as that. So I always use pre-grafting technique because in my opinion, it's enhanced the fusion rate. So before inserting the cage, I insert the graft using a specialized instrument like this. So you can pack the graft and 1/3 anterior on the this space. So after packing the graft, you can insert the cage, and you can enhance the cage under endoscopic view and fluoroscopic control. Okay, so this is the result, and you followed by minimal invasive screw placement. And if you compare the skin incision, yeah, you have more skin incision, of course, compared to biportal technique. But in my experience, is no difference pain post-operative between uniportal and biportal technique. So in conclusion, in my opinion, uniportal interlaminar approach, the most troublesome step of the surgery is the cage insertion. It is the most troublesome step of surgery, and you need more instrument compared to a biportal technique. And it is good if you have a 3D expandable cage. And the last is how about the fusion rate? We are talking about the technique implanting the cage using endoscopic. So, but none of the speaker, if I'm not mistaken, review the case of the fusion rate, whether it is comparable or better than a conventional technique. So thank you. Advice and comments are highly accepted. Back to you, Dr. Malcolm.
Dr. Harmantya, that was a very, very interesting presentation by you in using a uniportal technique for fusion. And I think I really appreciated what you are doing. It's exceptional work. I really wish you progress in that
Thank you.
and get more success for us and have a properly published series over there. Uh, there was just one question, personally speaking. Uh, now that you have shifted to Uniportal Fusion from Biportal, do you find it more convenient?
Yeah. So now I'm still convenient with biportal technique because, like I said before, the most important, the most troublesome technique is inserting the cage. So
Yeah,
I'm still developing a way.
you are putting a tube into the mouth of the disc. So
Yeah,
they're
yeah,
bypassing the entire neural structures. You're not worried about where is the cord, where is the root.
yep,
So
yep,
that's a wonderful thing that you're doing.
yep.
And actually, that is exactly what Master Yoon Sung Kim, when he had his presentation and he showed us those special tubes. We used to use those tubes in cervical spine, bi-pronged two-tang tubes so that we could see along the disc.
Yep.
It used to keep the disc space open so that you could go right up till the posterior edge of the cervical disc and stretch out the PLL.
Yeah.
And that is exactly the principle that Dr. Kim is now using in his monoportal technique of securing a passageway to the disc. And I think that's exactly what you are doing. You are
Yeah.
using a normal cannula, but
Yeah.
so it's wonderful. It's wonderful to have to listen to you today.
Thank you.
Congratulations. Wonderful, wonderful lecture. Thank you, sir.
Thank
Thank
you.
you so much. I will now invite Dr. Asrafi Riskigatham. Dr. Asrafi, are you there with us?
Yes, I'm here with you.
Yes,
Dr.
please start your
Malcolm.
screen sharing.
Yes, I will start my screen sharing.
Thank you. We'd like to hear you.
Yes. Yeah. Can you see my screen now?
Yes. Welcome, sir. Welcome.
Okay. Okay. Thank you very much, Dr. Malcolm. So once again, thank you for the opportunity to present my work here in the International Endoscopic Spine Society. So my topic today will be the biportal endoscopic spine surgery for degenerative lumbar problem in Indonesia. So this is our location. So I live in Jakarta, Indonesia. So this is our quite big country, and this is my hospital. This is the Fatmawati General Hospital. So we have been doing the endoscopic spine surgery since 2008. So why actually we are doing the endoscopic spine surgery is we try to reduce the local operative tissue damage and systemic surgical stress, as also mentioned by the AO Spine MIS curriculum in 2018. So we want to preserve as much as normal soft tissue as possible. Like in this picture, this is the pre-operative picture of a patient with a normal spine MRI, and this is after open surgeries with pedicle screw. We can see that there is lots of muscle damage on the posterior part. And this is after the endoscopic procedure. We can see that there is some inflammation and edema on the posterior part, but it is quite acceptable. So this is our roadmap in Indonesia. We started in 2007 with the Uniportal system. And in 2016, about 4 or 5 years ago, we started to do all full endoscopic uniportal stenosis decompression. By 2017, we try also the biportal endoscopic decompression and also fusion. I don't know whether it is going backward or forward from the uniportal, but I think that the biportal endoscopic decompression and fusion has lots of advantages for the management of lumbar spine and also spine in general. So if we look on the evidence of endoscopic spine surgeries, at first, this is the endoscopic spine surgeries I found in PubMed. We saw that lots of journal published for quite a long time, and we found around 4,000 results for the endoscopic spine surgeries. But for the biportal itself, we can only see around 60 results. So it means that it shows many of surgeons adopted this biportal endoscopic system in their practice. So I try to adopt the biportal endoscopic spine surgeries, and if we look at the results of the study, that the result is quite all right. The improvement of the FAS of the back is not really bad compared to the open lumbar microsurgeries, and also the operative time also good. And how about the fusion? This is one of the paper published by Master Son. The result is also good compared with the open conventional posterior lumbar interbody fusion. We can see that the fusion rate is also good, also comparable with the conventional lumbar interbody fusion. So this is just some of the perspective. Probably most of you have already known about this. The open spine surgery is actually the most natural working zone for us as spine surgeons. And this is the uniportal endoscopic spine surgery. So we only have one tube and one working channel. So in my opinion, this is actually harder for us and as an orthopedic surgeon to do, because the maneuver is quite different compared with the biportal endoscopic surgery. So in biportal, we have one channel for the view and the other is for the working zone. So this is, in my opinion, is very, very natural, especially for the orthopedic surgeon who's also been doing the arthroscopic surgery. So this is some of the differences between the uni and the biportal system. So my main concern is here, the mobility. So for the biportal, it's very, very mobile. So you don't need the your lens to be going on the same direction with your instrument, because with that case, you can just put your viewing portal on the same side, and then you can do lots of things with your working hand. And the other is actually just normal differences between the single and the two portal procedures. And also, we don't need any investment for the biportal endoscopic surgery. So it's actually better for those of us who wants to start the endoscopic procedures. So this is how I prepare my operating room. So I always use two bolsters in the patient. So I always try to put the patient in flat interlaminar space. So this is all the instruments that I use. Sometimes I use the 30 degrees endoscope, or sometimes I use the 0 degrees endoscope. So it depends on the situation. Sometimes in the very, very high tilt of the intervertebral space, sometimes I use the 30 degrees endoscope to evaluate the fusion bed clearly for when doing the endoscopic fusion. So I usually always try to draw all the landmark that we can use in our field. So this black dots is the location of the viewing portal on the top and working portal on the down here. So this is the X-ray. We do the triangulation and meeting. I always try this maneuver to clear up the muscles above the lamina, and I would like to make sure that the water flow is also good before doing all the procedures under endoscopy. So these are several cases that I've been doing. For first one is the simple disc herniation like this, L5S1 disc herniation. Probably for those of us who's been doing the uniportal surgery, probably we can just preserve the ligamentum flavum without damaging without removing all the ligamentum flavum. There is so like this in this left video, we did the surgery under normal biportal endoscopic procedure. So we did the laminotomy and then preparing the flavum, removing the flavum, and then we can see the thecal sac clearly. And after that, we can mobilize the thecal sac to see the this space. But I try to modify my procedure. So in that case, by doing the biportal endoscopy, I try to preserve the ligamentum flavum, so to prevent fibrosis on the later on. So I try to preserve like this, so making some cut on the ligamentum flavum on the top side and also on the lateral part. And then after that, I retract all the way the ligamentum flavum and the dural sac. So by this way, I think that in the future, the fibrosis formation is not really that bad by doing this kind of technique. So we can still see the ligamentum flavum here over the dura. So I hope that the fibrosis only stays here up on the top and also on the lateral part. So this is the result after the surgery. The result is quite all right. This is the result after preserving the ligamentum flavum. So we also did some endoscopic discectomy for this calcified disc. There is quite a lot of case in Indonesia with calcified disc because most of the people doesn't want to have a surgery at the first place when they have the symptoms at first. So usually they just wait, and then after that there's a calcification of the disc. So when doing a calcified disc decompression or discectomy, sometimes we have to open up the shell over the disc. Like this, we can see there's a very tight thecal sac here. There is a calcified disc, and sometimes it is hard for us to mobilize the thecal sac. And after we mobilize the thecal sac, sometimes we have to drill a little bit of the on the top of the disc before we can do the discectomy. So like this, and sometimes by doing this, we can have dural tear. So we have to do it very careful. So in this case, we did this surgery using the 30-degree endoscope. As you can see, there is almost no difference between the 30-degree and 0-degree for this kind of procedure. So this is the result after the surgery. There is still a remnant disc on the right side, but the patient is doing quite all right since the patient only had single-sided symptoms. And also, this is also some disc cyst. We did also excision of the cyst under endoscopy. So this is one of the simple case that we can do using the endoscopy with Biportal. We can see that the image is very clear, and we can remove the cyst. We can excise the cyst in very good condition. So this is the imaging result after the procedure. And also some endoscopic fusion for this patient. This is a spondylolysis patient, so female with spondylolisthesis. So basically, there's no compression on the nerve itself. So there is slight compression on the foraminal side, especially when the patient bend forward. But on the central canal, it's quite all right. And the patient will complain of back pain. We can see here on the 3D mesh, there's pars fractures. So what we did was doing the biportal fusion for this patient. So we prepared the lamina and then doing the flavectomy and then going directly into the disc space and then preparing the disc. The advantages of this endoscopic fusion was we can see Endplate clearly, and we can prepare the Endplate better to achieve good fusion in the future. So one of the advantages of doing Biportal is that we can use the normal open surgeries instrument, especially for preparing the disc. So this is a very, very good technique, I think, for doing the interbody fusion at the moment, since we don't have good tools for Uniportal system in Indonesia. So you can see this is the exiting nerve root, and then we protect the exiting and the traversing nerve root, and we can insert the cage. So this is the result. We have to put the pedicle screw up to the L4 to preserve the lumbar lordosis. So the patient, this is after the procedure, we can see the soft tissue is not really that bad compared with the open surgeries. So we also did some revision surgeries for using the biportal endoscopic technique. This is previously decompressed spine patient. So the patient now complains of back pain with listhesis of the L4-5 and the L5-S1. So what we did was endoscopic fusion like this. You see also using the biportal technique. So if you can see the video here, we have to prepare, we have to did some laminectomy again, and then find the fibrotic tissue near the bone. And this is the remnant of the ligamentum flavum that is still there, and some of the fibrotic tissue. And once we can get into the disc space, and we prepare the disc just as the previous slides. So, and then also we can have also the complication that's quite common by doing the biportal endoscopy. We can see here that there is a dural tear in after doing some discectomy. So usually happen in severe stenosis or when removing the ligamentum flavum. So usually I did nothing with this small dural tear, put some patch in. And also sometimes I have an epidural hematome formation. So usually this happens when the drain is not functioning well. So when having this kind of hematome, we have to evaluate the symptoms. Sometimes it is usually without the symptoms. So when without symptoms, I did nothing. So I only observe the patient. But when there is symptoms, I sometimes did the re-endoscopy again and removing all the hematome formation. So this is quite dangerous, especially for the risk of future infection. So this is also reported by Ju and Kim here for the hematoma after the biportal endoscopic spine surgeries. And one of the complications that I don't know whether some of you have encountered or not. So I have infection case for after the endoscopy. This is very, very rare, especially because due to the continuous water flow. But I had this one complication, but in this case it is a superficial infection, since this is only case of stenosis decompression by portal. But I also had one case of spondylodiscitis. But if we see from the PubMed, there is no discussing about the discitis after the biportal endoscopic spine surgeries. It's also, if we put the mark here in infection after biportal endoscopic spine surgeries, there are 3 results, but all of it are the infection, like epidural abscess treated with biportal endoscopic surgery, not infection after the biportal endoscopic spine surgeries. So in conclusion, the endoscope is very, very wide because it uses the principle of open spine surgeries, and the result is far more superior compared to open surgeries, especially in soft tissue preservation. And I think we could say that it could replace the open surgeries or even microscope for decompression procedure. And at this moment, we could almost say goodbye to open surgeries. So we only do open surgeries for several cases or severe deformity cases, scoliosis at the moment. So thank you for the time, and back to you, Dr. Malcolm.
Yeah, it is I who should say thank you for a very lovely presentation,
Yep.
Dr. Gandhi. We should all say goodbye to open spine surgery and degenerative spine. I do agree with you. The time has come.
Yes.
The world is changing. Corona changed us, and I think before Corona changes, endoscopic spine changed us. At least
Yes, of course.